of telemental health. And as Michaela mentioned, as part of a series on delivering telemental health. So we are sponsored today by the Mountain Plains Mental Health Technology Transfer Center. And so this is a SAMSA program, essentially under their cooperation. Excuse me, let me jump back. And they have different areas, including addiction, mental health, prevention. There's actually disaster technology transfer centers. And so we typically will communicate with people, educate people within Region 8. Oftentimes we go outside of that, but we have technology training across the country. I know that many of you are coming in, beaming in from this region, but many of you are coming in from outside as well. So we always put up a disclaimer that we need to say that these are my thoughts and my recommendations. Even though we're SAMSA sponsored, we have to have a declaration that it's not their opinions, it's mine. And then at the end of this presentation, we'd like you to fill out an evaluation. It's a way that we're able to continue being sponsored by SAMSA. They expect that we will send them information on how this was received, whether it was helpful, and this is one way that we're able to do that. So if you can take this brief survey, that would be great. One question I have is, so as I'm giving a talk, I'm getting pop-ups, and I'm hoping that this isn't happening on your screen. Are you just seeing the slides? Good, okay, thank you. So the objectives, describing common ethical dilemmas in telemental health, talking about solutions to those ethical dilemmas, and then also looking at the limitations of telemental health delivery. So ivory tower in the trenches. So that, COVID, the pandemic has really brought out, I think, discrepancies between what has been considered standard of care from an academic standpoint and really what we all do in the trenches. And it's important certainly to have, standards of care, to have, consistency across various treatment programs, but at the same time, many of us practice in very rural and some would describe frontier areas. As an example, my father was a country physician. I used to go on house calls with him. I used to do surgery assistance when I was a teenager. We had a party line. And so for those of you who are old enough, that just brings up the issue of confidentiality. If you have to say, Agnes, get off the phone, I'm talking to a patient. So things have, significantly changed, but this pandemic has brought out, a lot more issues and ways of engaging with people that were actually limitations, in between those times. So we'll want to talk a little bit about that. And I think, most of you doing this work can really recognize that. Definitions, we hear telemedicine, we hear telehealth, we hear telemental health, telebehavioral health, telepsychiatry, teletubbies, everything. And we're essentially talking about the same things. So telemedicine and telehealth are the broad areas under healthcare. For what we do, you'll hear telemental health. Telebehavioral health, really talks about both mental health and issues having to do with addiction. Telepsychiatry, a little bit more formalized. So HRSA says that telehealth is the use of electronic information, telecommunications technology supporting long-distance clinical health care, patient and professional health-related education, public health, health administration. But realistically, when we're talking about this technology, it used to be assumed that this was long distance. And actually, payment reimbursement required that there be X amount of miles between the practitioner and the patient. That's not the case currently with the pandemic and with the exemptions. In fact, at the beginning of the COVID 19 pandemic, we had some healthcare facilities where they were allowing patients to come in, but they were in the room next door doing virtual telehealth care literally 15 feet away. And so where initially the whole assumption was this was going to be long distance, rural, et cetera, that has changed. One of the big questions that's going to be discussed is what happens when things get back to quote unquote normal. I think the public for sure will demand that some of these changes that have occurred remain. And there's going to be a lot of pressure on third-party payers, et cetera, to continue that. Behavioral healthcare, as I mentioned, is really an umbrella term and talking about both mental health issues and addiction issues. So when we talk about behavioral healthcare, we're really talking about both mental health and substance use issues. It was interesting when I was over in Australia and talking on behavioral health, but they asked me not to use that term because they said, well, that's just what psychologists do. And so different parts of the region, different parts of the country, different parts of the world have different definitions as well. So it's important that we all understand what we're talking about. So we have this pandemic, and there was a public health emergency declaration, the CARES Act. There were, Medicare waivers, 1115, 1135, allowed for virtual care. So it opened up lots of opportunities for more providers, more types of providers to allow care, virtual care. There were still questions about, can I practice across state lines? And we'll talk about that and some of the ethical concerns there. There are actually provisions for licensure for telehealth only. So if a person didn't want to actually do anything more than virtual care, you can, some states will actually allow licensure for that. And here's just a site that you can go to look at the CMS rules on that. So issues related to interstate patient-client treatment. I'm a physician, so I use the term patient. Many individuals use the term client. We're using those interchangeably. So there are provisions where if there is an emergency where you're treating someone across state lines and it's a one-time thing, some states will allow that to occur without having licensure there. Then we know that there are interstate compacts. There are licensure pacts across different disciplines where a number of states will all say, we'll allow reciprocity. You just need to, inform us that you are seeing a patient in one of our states and you're good to go as long as your license is okay in your home state. Then there's expedited licensures where we're contacting the state that we want to see a patient in, saying, I need this quick. Are there avenues to do that? There's also something called the Uniform Volunteer Emergency Health Practitioner Act. That's a real mouthful, but that essentially, there's about 20 or more states that if there's an emergency, you can practice in any of those 20 states without having to apply for any licensure, notification, et cetera. You just have to make sure that your license is in good standing. So there's lots of different ways that we have been able to treat patients across state lines. However, despite people's beliefs, it's not a federal rule currently. There are state rules. And when we talk again about distant sites, originating sites, it's confusing, but the originating site is actually where the client is. The distant site is actually where we are, which seems, like a misnomer. But so essentially, we want to check with the states where the patient is, where we want to treat them and say, essentially, what are your current rules? And they are actually changing week by week because some states have allowed for virtual care reciprocity up to a particular time and then it expires. And so we can't just assume that we can go ahead and do all the treatment we want to do in this particular state. So I just wanted to let people know, so we were talking about Aberdeen. Today, there's a good reason for doing telemental health. There is a winter storm warning right where we're at. So those of you who are in South Dakota in particular, I don't have to tell you that, but other people around the country might might find that interesting. Those of us in the upper Midwest, telehealth has really been a great thing, particularly in the winter months, from a safety standpoint, from an engagement standpoint, et cetera. So when we're talking about ethics, you know, where there's law and there's ethics, and laws are things that you must do. You know, they're written in statute. Ethics are things that you should do. And when we talk about ethics, we're often talking about, you know, a systemic sort of thing as opposed to morals relating to an individual person. But ethics is derived from, you know, policies of professional organizations. So all of you, despite your discipline, or, you know, regardless of your discipline, you all have professional standards within your own discipline, whether it be social work, addiction counseling, nurse practitioners, PAs, et cetera. And there are standards of care within those professions. And those are things that should be allowed, but they're difficult to enforce. And oftentimes the enforcement comes under your licensure or your belonging to a particular association. And then the other thing that we recognize is that, you know, legal determinations don't always solve ethical problems and vice versa. So when we look at the fundamental ethical principles in healthcare, and this pertains also to telemental health, there are four primary principles. So the first principle, and actually the main one, is individual autonomy. So a patient or client has the right to choose or refuse treatment. And then the next is beneficence. So this is why we went into the business, to do what's in the person's best interest. We want to treat people well. And then there's non-maleficence, or sometimes you hear non-malfeasance, which is essentially doing no harm. And then there's the principle of justice or fairness, which has certainly come to the forefront in this pandemic. We know that some individuals, some certain populations are hit much harder than some other populations are. And, you know, part of the process of looking at this delivery of care when we come through this is what went well, what didn't go well, what do we need to change? So as we look at this, I want to talk a little bit about, you know, the autonomy standpoint, both informed consent, assent, patient choice, talk a little bit about dual agency, talk about confidentiality issues, boundary communication issues, moral injury. We'll spend a little time talking about that. And then on the justice side, fairness and advocacy. So with autonomy, you know, one of the questions is, how do you deliver informed consent and services or services in treatment? So when we are seeing somebody virtually, we may or may not have all the paperwork available. Hopefully we have a record of care, or when we're instituting care, we know the person's age. We hope that we're treating an adult. So when we assume that someone is the age of consent, we actually will know that. You know, we may not be able to give them all the handouts or the things that we typically would when they're in our office. And so some of the things we want to think about from an ethical standpoint is, you know, how we provided information such that the individual can make, you know, a good informed consent to treatment. And then, you know, how do we determine that? And then how do we document that? And I think it's important also to talk about the difference between consent and assent. Most of the time we are assuming that A, the person has capacity to consent, and you know, B, that everything what we told them they understand, and that therefore, you know, and they signed a form, and so they've been given consent. Well, typically now they're not signing a form, and you know, what I've oftentimes found myself doing is asking myself, did I truly give informed consent to this individual, or did I give enough information for them and for me to feel comfortable going ahead with treatment, recognizing I really need to follow up and give them more information in the future? So an example would be, I would typically see patients with really serious mental illnesses. And so someone who might be in the midst of a psychotic episode, are they truly going to be able to understand everything that I'm talking with them about in terms of treatment and consent to that? Maybe not. Does that mean I don't go ahead and provide treatment? No, but I recognize I need to follow up and make sure that everything that we've talked about, they are clear, clear on, particularly as they become, more cognitively, able to do that. The flip side is obviously, do they have an advocate? Do they have someone else present who can assist them in that? But I think it's important for us as we, know that there are limitations in terms of what we're able to provide, particularly with hard copies and records and things like that, and forms, that we're thinking about, the consent issue. Another, issue in terms of autonomy is what choice do patients have in the mode of delivery of services? And I'm going to talk about that as we talk about dual agency here. For many people at the beginning of the pandemic, they were coming in, healthcare organizations were saying, well, we'll have them come in. And then people were saying, no, you really shouldn't come in. Some particular patient populations, particularly older people, really wanted to come in and see their providers, or people with serious medical complications wanted to come in and be examined. And so, there are ethical issues there. So for example, dual agency. So beneficence is, doing what's in the person's best interest. Sometimes we struggle with, am I the primary agent of the client? Am I an agent of my healthcare organization, my clinic? Am I an agent of some other, organization or facility that I'm belonging to? And so, for example, and I heard this actually during the start of COVID, your healthcare organization prefers you to use a particular type of telemental health or even in person. So example, we're not getting reimbursed much on the phone. So can we do the video audio conference, and or can you have them come in, even though that's not in the person's best interest, but it's in the facility's best interest from a fiscal standpoint. So that's one of those ethical dilemmas about, how do we manage that? And so, I think part of it is just being really transparent and also trying to advocate what's in the patient's best interest, realizing that there is other pressure. And so I'm not sure if any of you have experienced that, and maybe when we go to the chat room or open up the mics, we can talk about that. So when we're talking about harm, in a disaster or crisis, business as usual is no longer the case. So right now, there have been lots of exceptions in terms of how we provide care. We also know that things are a bit looser. And so we're able to pick up the phone, or we're able to do, texting, or we're able to do other sorts of things that maybe we hadn't done as much of during, pre-COVID. But it continues to be important to recognize that as things have changed, are we aware of where the lines are? When we're crossing those lines, why we're crossing those lines, how we document that, how transparent we can be about that. And so, I think that's going to be an important thing to continue to think about. And the same thing with standard of care. And I'm going to talk a little bit about, moral injury, as I mentioned. So, some of the issues are lack of access to electronic health records, or the records that you need to provide good care. That doesn't mean you can't go ahead and provide the care, but that you recognize there are some things that I need to follow up on, or that I need to document that we need to discuss again next visit. That's been a real problem in terms of the virtual care, is we might not have access to everything we would typically need. And we don't want to drop that. We don't want to forget that. And then the issues in terms of confidentiality and privacy concerns, those have changed. There are rules that you're not going to be audited for, HIPAA violations, things like that. But we want to be mindful about, what has become standard during, a crisis, and, what returns to standard of care. So when the pandemic hit, there was the notification of enforcement discretion. which had to do with, HIPAA. And so they came out and said, essentially, you won't be subject to penalties for violations of HIPAA privacy, security, and breach notifications. Now, there were recommendations that if you're using platforms that weren't necessarily thought to be HIPAA compliant, that you might want to just do a business associate agreement, which then covers HIPAA. There's the business associate agreement. So, if you were using Skype for business, you would contact Skype and say, oh, do you have a business associate agreement? And essentially then that would tend to cover from HIPAA violations. But this notification of enforcement discretion says you're not going to be subject to penalties during this emergency. However, it doesn't affect application of HIPAA outside of telehealth during an emergency. And in terms of 42 CFR Part 2, the issues surrounding substance use treatment, to be honest, there weren't a lot of substantial changes during the pandemic regarding this outside of, MAT treatment. You don't need to necessarily do an in-person evaluation. There were waivers in terms of being able to provide care, but essentially it's still, you can divulge, you can breach confidentiality in an emergency, but outside of that, the rules really haven't changed much. Now, I know also that I think and Michaela may be able to correct me, I believe on your schedule of these talks that there is going to be discussion also about current legal issues with the pandemic. So I don't want to, belabor that. You'll have opportunity for that as well, those discussions. So digital professionalism is an interesting concept. And Glenn Gabbard is a psychiatrist who's written a lot on medical marriages, on issues relating to mental health and providers. And as virtual and digital communications become the norm, how do we manage issues of privacy? I teach psychiatry residents, and some of them were shocked to find out, patients can find out where you live by going online if they're clever. We can find out where patients live. And so, there's lots of things on social media out there. And when is it appropriate to go looking up a client? We don't want to be voyeurs. And it's not appropriate just in terms of being curious. There may be times where it's actually, appropriate to find out more information about a client, particularly if there are concerns in terms of danger, other risks. But, the term they use is targeted internet searching. So, how do you deal with it when a patient comes and says, I looked up, where you live, et cetera. How do we manage that? And all of us have had to deal with those sorts of issues. And there are different ways of dealing with it depending on our perception of the person's intent. And then vice versa. We may be curious about a particular patient, but that doesn't mean we should go, surfing on social media. However, if a patient says, I accomplished this and, I'm pretty proud of it, and it was implied that, it'd be, okay, and in fact encouraged to look that up, I think that would be totally appropriate. But, those are the sorts of ethical issues that we have to think about. Before we end today, I think one of the main themes I want to bring home is when we're in doubt, and the good news is as mental health professionals, we're trained to identify when we're not feeling, things are quite right. When we're self-reflecting, we always want to reach out and get some feedback. And so I think it's really important when we're thinking we're crossing the line or we're not exactly sure about things, regardless of how isolated your practice might be, there's always someone, there's always a colleague, there's always an organization or an association that you can reach out to, a listserv, and say, I had this particular situation and I'm feeling a little bit uncomfortable about it. I used to be involved in, I was on our state medical licensing board and also on our professional health program board statewide. And routinely what would happen is the practitioners who were isolated, who were solo practitioners or small clinics or rural, and they didn't engage frequently with their colleagues, oftentimes those were the people who got in trouble because they didn't bounce things off of people. They didn't either recognize or know when they were crossing the lines. And so I think it's just really important to get feedback regardless of how experienced we are. So consequences of these ethical dilemmas, particularly in terms of resources. There's the concept of moral injury, and that's being unable to provide what you know is best for the patient or the client due to conditions beyond your control. And a good example of that obviously is, when New York City began to have they were really the hot spot, and there wasn't enough personal protective equipment, and there weren't enough treatment resources for patients. It was really moral injury. They were doing the best they could, knowing that there was so much more they could have done had that been available. And then, you point fingers. Why did this happen? Why is it continuing to happen? So that's something that some of you may have experienced. When initially it was discussed, it was really more onerous, the emotional, physical, spiritual harm people feel after perpetrating or bearing witness to acts that transgress deeply held moral beliefs or standards. And so many of you may be experiencing that now, not being able to provide the care that you wish and know you should be able to provide because of a lack of resources. And with virtual care, with telemental health, that sometimes does happen with if we don't have the appropriate broadband, if our patients don't have that, if things are falling apart, from an infrastructure standpoint, that hits us all. So the last principle in terms of healthcare ethics is justice, and that's essentially fairness, and that's really a difficult thing right now because in times like this, there's the haves and have-nots, and as I mentioned, particular populations are suffering more. Those who are in poverty, those who are already marginalized are even more at risk during times like this. So one of the dilemmas that we're dealing with as providers is, how do we reach those people? And once we come through this pandemic, and how do we advocate to make sure that those people have access? From a telehealth standpoint, one of the access issues is, broadband. In our rural and frontier areas, do people have access? And if not, how do we, make sure that people hear the need for them to have access? How can we be creative and allow them to have access? And some organizations have, sent out, VPN, flashcards, things like that. Some have had grants to allow for iPads and to have access as well. So there are lots of issues that have to do with, the populations that we deal with who may be already marginalized, who don't have the infrastructure, and so what we can do about that. So we've been talking about, the issues of engagement, of treatment, but, what about disengagement? And that's also an ethical dilemma. So when we talk about termination of care, and I just wanted to touch on this because, it certainly comes up as part of our normal practice. We can end the patient-client relationship or the provider-client relationship if we both agree that that's the best thing to do. If the client says, I don't want to see you anymore. Patients' improved condition, we can't necessarily assume that, but many times people are just feeling that much better and they've decided they're not going to follow up, etc. Withdrawal by the provider. There are oftentimes, safety issues, reasons for termination of care that usually will go through, the organization's attorney, et cetera. But also if you all have decided that, you're going to withdraw, then you want to do that with written notice. We have an obligation to try to attempt to help them secure treatment if it wasn't one of those where it was a safety issue and we no longer maybe have that obligation. How do you obtain records? SAMSA actually has a great website. So if people are moving, they have a provider locator website on the SAMSA website where you can punch in the zip code where you happen to be living, and it will come up with all the different mental health providers that are in the region. And so the bottom line is you can't just abandon. However, if there are safety issues, then there are legal ways of going through that. And so you can refuse to accept, treat, advise someone if it's not arbitrary, if it's not discriminatory. But again, you can't abandon. Typically, you would want to try to coordinate care with someone else, maybe in your facility, maybe not. You can, for claims of conscience, if you inform the patient of treatment options, make appropriate referrals, and if it's not an emergent situation where delay would cause harm. So, you do have some choice in terms of treating patients, but there are, rules and regulations around that. So we were talking about treatment, but there's also what we're doing right now virtually in terms of telemental health. It's education. And so there are ethical issues there too, such as maintaining confidentiality. So I've got the MHTTC logo down there. There's also Project Echo. I don't know if any of you have heard of Project Echo, but that's another platform for educating other providers on certain healthcare issues. And so it's important, though, when you're talking about a particular case, a particular patient, particular client, that you're not divulging confidential information, protected health information that could identify that person. And so same thing in our chat. If you have particular questions about a client, or how to manage something, we can't talk about protected health information when it's not been okayed by the patient themselves. And then we also want to know when we're crossing the line between simply giving general education, or even if there's a question about a specific case, speaking generally enough so that we're saying in instances like this, as opposed to this is exactly what you should do with this particular patient. That's an issue that we want to be cautious about, because then we're essentially giving clinical advice on someone that we haven't actually evaluated. So telemental health, has been great. And as I mentioned, particularly in our rural areas, it's been wonderful, but it's not ideal. And when I say it's not ideal, it means not that it can't or shouldn't be done in certain instances, but, if we have individuals at high risk of self-harm, do we have an adequate safety plan in place, someone on the other end, resources on the other end that we're aware of, phone numbers that we can call, so that we're not stuck in this particular situation of, oh gosh, now what do I do? So we want to be mindful of that, obviously. If we have people with significant unstable medical conditions, particularly if we're responsible in some part, for their treatment, that might not be ideal. But again, during this pandemic, we're providing care to lots of people in their homes who we wouldn't typically be doing this for. Individuals who require a physical examination, and maybe not even a formal examination, but for many of you, so let's say if you're doing addiction treatment, or if you're prescribing medications, there are a lot of times where, I'll want to be able to see, is there a tremor? Is there any sort of movement problem? It's not necessarily something you ask for, but sometimes it's helpful to know how disheveled they are in terms of, is there an odor or things like that. So it's not ideal for certain circumstances. There are some programs where, given the originating site and the software and hardware that they have, sometimes there are cameras you can zoom in and you can do quite a bit, but That's not always available to everybody. And so, obviously not ideal for that. There are certainly other times where if there's someone else there who can advocate and who can maybe even assist in checking out, does this person have, a tremor, or, excuse me, teaching nurses to check for a particular type of rigidity, et cetera. But again, not ideal. And then not all of us have the skill sets, nor the broadband, the equipment to necessarily do this. So sometimes it's the best we've got. As I mentioned, sometimes it's not ideal, but we've been finding more and more during this experiment of the pandemic of things that are doable and things that are not. And the other part is, sporadic care when continuity is necessary. So one of the things that we've seen during this pandemic is a proliferation of people from around the practitioners from around the country saying, we will treat you. And so these, telehealth, telemental health companies, some are very good, but for some people, it's actually not best that they bounce around or that they see people who they don't necessarily know or get the chance to know them well, because sometimes that's not in the patient's best interest. So again, as we're going through this pandemic, doing telemental health, we want to just continue to be mindful about what has changed, what the exceptions have been, the rules that have changed in terms of standard, and then what we will want to be looking at going back to. So I mentioned, the issue of when you're stuck. So again, the most important thing is recognizing when you're stuck. And then secondly, being able to reach out for help. That was probably the most useful thing I learned in training was when you're stuck, you ask for help, you expand the field. You go to a colleague, a peer, a former mentor or supervisor and just say, this is what I'm dealing with. And then we want to be documenting our decision-making process. So another important piece of advice I got, I learned about in training was, there's the concept of omission of fact and omission of judgment. And essentially what that means, and it's again a dilemma with telemental health because there are some resources we're missing or some pieces of information that we're missing as we're providing care. So omission of fact is you didn't look at everything. And so things that you should have had available or looked at, you didn't. Omission of judgment is much more forgiving because we're all human and nobody expects us to be perfect. And so if you've documented, this is what I was thinking, this is what I knew was available or wasn't available, and this is where I landed in my clinical decision, and there happens to be a negative outcome, a bad outcome, that's much more, people are much more forgiving of that than if, no, I just didn't bother to look, or yeah, I knew that was missing, but I didn't follow up on that, et cetera. So, it's a helpful reminder to think about, there are things that we should have available. If we don't have them available, we should know that and follow up on that. But if we make our best judgment based on the information that we had or should have had, then that's as good as it gets. They can't expect any more than that. So that's all I had for this visit to talk right now. I just want to remind people on this GIPRA here, if you can take the brief survey. So do we have, Michaela, do we have any comments or questions, or did you want to open up the mics?
Yeah, so in the comments we have, can you obtain client and or parent signatures on consent, treatment plans, and etc. using a virtual portal in the EMR when we cannot verify that the person signing the form electronically is actually the person who should sign it?
Well, it's not unlike, do you know if they're actually the guardian or not, or the parent or not? And so it comes down to, how extensively are you going to investigate that? So you would assume that, you can ask them to to show their ID or their driver's license or things like that. But you can, we make assumptions. There are higher standards. So let's say in a hospital setting, remember, they're checking your ID band, you're checking their birth date, they're asking those formal questions in a higher level of care. In places where there's not as high a level of care, there are lots of assumptions that occur. So if in good faith you have good reason to believe that they are who they say they are, then I would say, yeah, you'd proceed. You can always ask them for more identification. In terms of the question about the electronic record, really depends on the record or the type of platform that you're using, but typically you can. The other thing that you can do is, and then they have access to their patient portal and can do those sorts of things. The other thing is, depending on the software that they have back home in their computers, et cetera, you can send them a PDF and they can, if they have Adobe, they can sign it and send it back, et cetera. That's a little dicier. Sometimes they have to sign it and scan it if they have a copier at home, et cetera. But yeah, ideally it would be, through the portal.
Okay, and it looks like we don't have any other questions on the chat, but the microphones are open that if any of you want to unmute and ask a question or whatnot, you can.
Hi, so this is Evelyn. I'm based out here in Los Angeles, so I have a question.
Mm-hmm.
So most of my providers are doing their services over the phone.
Yep.
And so one of the things that we have into is it just being really difficult, especially when they're new, to really know who, if that's the person who's supposed to be on the phone. But patients are just kind of falling off, and so they're either not responding. Even if you try reaching out to them, it's kind of hard to kind of leave them a voicemail message.
Mm-hmm.
I've attempted, when I'm able to find their email, to even email them, but there's just no response at all. And so you're left wondering, as a mental health provider, what do you do next? Because
Yep.
It's very different when they used to come to you and
Absolutely.
you saw them face to face, and so you were able to build that engagement. And now what I'm seeing is that
Yep.
they're just gone, and you don't know what happened, and you don't know how to re-engage.
No, that's a great point. And actually, I also do consultation for a federally qualified health center, and they run across the same problem from a behavioral health standpoint, where people will just disappear. And it brings up the point of at the initial contact, and it's dicey because you're trying to engage and you don't want people to be paranoid either. But can you gather enough information? Family, other contacts, other ways of communicating, if for whatever reason things fall apart, that we could reach out to you. But a lot of us are left with, well, we've done the best we can. Sometimes, if we have a last address, if people aren't homeless, or if they've been staying at the shelter, et cetera, can we drop them a note, that way? I think the important thing is that you decided, who should you follow up on, in good faith, and then, be able to show that you have that attempt. So whether it's calling, 5 times, or whether it's trying to contact their last, contact that you had on record, or sending a note, those are all sorts of things. It's just not only doing the right thing and trying to reach out, but also documenting, that you tried that. Outside of that, that's about all you can do. Unless people are at the point where they don't have capacity, where there's, more concern about potentially self-harm, where you might ask, for law enforcement or someone else to check. We just need to document that we made a good faith effort to try to contact them. I just wanted to talk about or answer this other question that had to do with what do you suggest when you can't get a consent? Should we be documenting a clinical note? And actually, from my standpoint, a lawyer would not say this, but from my standpoint, my documenting their consent and maybe what we talked about in my mind, is better than having a signed form that really only tells me that they just signed something. So typically you want to do, the signed informed consent, but oftentimes what I'll do is I'll say, I may have a general spiel that I'll give about something, particularly, let's say if it's medication. And so elsewhere I've documented that I give this standard spiel. And then I'll mention, well, the patient verbalized understanding, so I'll ask them back, okay, what's your understanding of our discussion here? And they'll say that, and then I'll document that. And in my mind, that's as good or better than a signed informed consent. However, you'll want to always try to get an informed consent signed when you can. But absolutely, if you've given information, you're aware they've understood it, you simply document that in the note. Okay, I think that is all that we've got right now. David, do you have any other? You've mentioned the evaluation form. So do you or Michaela have anything else to add?
I do not. We thank you all for joining the call. We really appreciate it. And David, if you have anything.
I'm envious of you in LA and elsewhere who aren't up in the upper Midwest right now, but it's actually very nice snow. We'll try to send you some if you want it. So thanks much for attending. Appreciate it.
Thank you. And if you have not signed up, please go and sign up for the rest of the series as well too. So, and I will send out, along with our surveys that we're doing, I will send out the link to the survey from the MHTTC as well. So thank you.
Thanks, everyone.